According to current European guidelines, we can distinguish the indication for BPH surgery in relative and absolute. Absolute indication, that is when complications of BPH and BPO occur, while there is relative indication in patients with LUTS refractory to medical treatment. In reality, it would be correct to also consider a preferential indication, corresponding to the patient's desire to have surgery to improve LUTS without medical therapy. This slide summarizes an old and outdated concept of surgical management of BPH. However, in recent years, there have been radical changes. For development of novel surgical treatments, many of which minimally invasive, concept of personalized medicine, importance of patients' involvement in the decision-making process, and raising awareness towards the preservation of sexual health. Finally, the counseling has acquired a central role in the choice of surgery. Today, the choice of surgical techniques depends on several factors, such as the prostate size, the median lobe, the age, comorbidities, risk of ejaculation, type of anesthesia, availability of the operating room, patient preference, availability of devices, surgeon experience, and costs. Obviously, it's essential to base the therapeutic offer on the most current scientific evidence. According to current European guidelines, the available evidence allows us to classify surgical techniques for BPH into consolidated and under investigation techniques. This difference must always be kept in mind and the patient must be informed about it. Based on what has been said, European and American guidelines have created flowcharts on the surgical management of BPH. However, these should only be considered as guides for the surgeon. Often the choice is not so easy and automatic due to numerous variables coming into play. Theoretically, today, the interventions of choice for BPH according to the prostate size will be 2IP for less than 30 milliliter, 2RP between 30 and 80 milliliters, and endoscopic enucleation prostate over 80 milliliters. But this is an oversimplification. First of all, the cutoffs are neither standardized nor rigid. Then, QRP can also be performed for small or large prostates. It's the traditional gold standard for the comparative study on BPH surgery. Endoscopic enucleation can be considered a feasible procedure regardless of prostate size, and it is considered to be the new gold standard by many authors for this reason. Open and minimally invasive simple prostatectomy are possible alternatives for large prostate to endoscopic enucleation, especially for giant prostates. In addition, all other procedures have been studied mainly in medium-sized prostates, so as possible alternative to QRP. But for most of them, there are several studies that indicate potential application also in large prostates. An obstructive median lobe may be a contraindication or simply be associated with reduced effectiveness of BPH surgical treatment. For example, this is a contraindication for ITIN. Especially in young men, the preservation of ejaculatory function, and especially in old men, comorbidities and their performance status may influence the indication and type of BPH surgery respectively. Moreover, it's important to consider that the younger the patient, the theoretically greater the risk of reintervention to the prostate tissue regrowth and BPO recurrence. So it's important to inform the patients about it, consider this issue when there is no absolute indication of BPH surgery, and consider that some studies have associated some BPH surgical procedure with a lower risk of reoperation. In patients with hemostasis disorders, laser vaporization should be offered as first-line treatment, but also laser enucleation appears to be safe. Frailty or IASA score are not specific contraindication to any type of BPH surgery. However, in this population, appears to be reasonable to avoid particularly invasive intervention and prefer ultra minimal invasive surgical treatments. Regarding the indwelling bladder catheter, there is insufficient evidence supporting the superiority of one surgical procedure for BPH over the others, so it should not influence the choice of surgery. A lot of other comorbidities should be considered in BPH patients because they could influence the indication for surgery or the type of BPH surgery. For example, neurological disorders, psychiatric disorder, urethral strictures, previous BPH surgery, bladder diverticular stones, suspect of diagnosis of prostate cancer, and joint diseases. Some patients cannot or do not want to undergo general anesthesia. Furthermore, operating rooms are often busy due to the long waiting list for cancer or for other surgical procedures for benign conditions. In these cases, we can consider the ultra minimal invasive surgical treatments. They are surgical procedures for BPH that can be performed in the office setting using sedation and or local anesthesia. Another important factor is the risk of anejaculation. Ejaculation plays an important role in sexual satisfaction and it's essential for reproduction. Traditional BPH surgery is associated with a high risk of ejaculation, and one of the main drives behind the development of minimal invasive surgical treatment for BPH was to improve sexual outcomes, especially the ejaculation. For this reason, in young men and in all patients who wish to preserve ejaculation, some intervention with low risk of ejaculation may be offered, such as urethral lift, Rezum, Aquabeam, ITIN, TPLA, and Optilube. Also, the cost may influence the surgery, the availability of devices in the center, the type of procedure performed with a device, and patient preference if surgery is private. As I said, patient preference is essential in the choice of surgery and indication of BPH surgery. We often hear, "Dear doctor, I would like the laser therapy, the robot, the vapor therapy," for example. So, the marketing is pivotal in this area for the patient. We need to understand patients' preferences, provide appropriate counseling, and finally, communicate the feasibility of the request of patients. Obviously, a specific surgery cannot be offered if the devices to perform it are missing or there is no one who knows how to perform that surgery. On the other hand, the more devices available and the more procedures the surgeon is experienced in, the greater the range of surgical options can be offered to the patient, allowing for the best procedure to be indicated. And this is an advantage of high-volume specialized centers. I won't conclude with this proverb. Indicate the correct treatment and the patient is already halfway to therapeutic success. Thank you for your attention.